I'm going to try and talk today about sleep in children, particularly children with Prader-Willi syndrome, and touch on many different aspects of sleep. So I want to start by talking about what sleep really is. In childhood, children can sleep as much as half the time, and I think we really need to focus on how important that is for all of us as well as for children in terms of our daytime well-being, our daytime functioning. And children with Prader-Willi, of course, are no different. Sleep is incredibly conserved between individuals, and it's divided into two different stages, and I'm going to just talk briefly about these because it is relevant in terms of Prader-Willi syndrome. We get rapid eye movement sleep, which is literally when the eyes flicker during sleep, and that's when we're dreaming. And then one of the important aspects of rapid eye movement sleep is that our muscles are deactivated, so we get hypotonia during REM sleep, and that's, I guess, so we don't get up and run around while we're having our dreams or be very active during the night. But that becomes important when we talk about sleep apnea, which can be compounded in REM sleep because of that hypotonia. And then there's non-REM sleep. So this is a typical, what we'd call in sleep medicine, a hypnogram that shows the different stages of sleep in different colours. And light sleep is the yellow and green, and deeper sleep is the blue colours, and rapid eye movement sleep is these reddish brown colours. And all of us are very similar. We have most of our slow wave sleep or very deep sleep in the first part of the night, and most of our rapid eye movement sleep in the latter part of the night. But we basically alternate between non-REM and REM sleep in a regular rhythm throughout the night. That timing and regularity of REM sleep particularly is very predictable, and that's one of the fascinating features of Prader-Willi syndrome, is that control of where REM sleep appears both during the daytime and at nighttime can be affected. So there are many different aspects of Prader-Willi syndrome that can affect sleep, both the primary features, particularly hypotonia in infancy, or if obesity develops, that can certainly have an impact on sleep-related breathing disorders. Of course, there's behavioural aspects as well. Like any child, some children have difficulties getting into bed, settling at night, or have frequent wakings during the night, and those problems are more common in children with developmental disorders. Hypothalamic function we've heard a bit about this morning, and a hypothalamus, amongst all the things that have been mentioned in terms of temperature control and appetite regulation and hormone function, also has a key role in the control of alertness. So the fact that we're alert during the day and we're sleepy at night, the hypothalamus has a really central role in that. And it also plays a role in the organisation of REM sleep, as I've mentioned, so that we have REM sleep in that predictable pattern through the night. People with Prader-Willi syndrome have also been shown to have a reduced response to hypoxia or low oxygen levels and hypercapnia or high CO2 levels. So if I put you in a box and lowered the oxygen level there, you would increase ventilation, same with high CO2. So if you increase the amount of CO2 someone's breathing in, they'll start to pant. And that is variable between individuals, but it is in general reduced in people with Prader-Willi syndrome. There's also reduced arousal from sleep. So if someone's asleep and you make them hypoxic or low in oxygen, they will wake up. So it's a protective mechanism if you're under breathing that you'll wake from sleep. And that response is also reduced in Prader-Willi for reasons that we don't completely understand. So an overview of sleep disorders in Prader-Willi syndrome. I'm mainly going to talk this afternoon about sleep disorder breathing and the different types of that, and I'll come back to a bit of an explanation of all these different things. It's already been mentioned today that people with Prader-Willi syndrome can have excessive daytime sleepiness that is sometimes not related to a disorder of breathing during sleep and can be a primary abnormality of hypothalamic function. And secondary narcolepsy is also in that group that causes excessive daytime sleepiness and some abnormalities of the way particularly rapid eye movement sleep is controlled. So narcolepsy is a primary genetic disorder, and in this case it's thought to be related to the hypothalamic dysfunction. I put behavioural insomnia of childhood to remind me to mention that sleep problems are really common in children in general. Maybe a third of preschool children, parents would say their child has some difficulties with sleep or some problem with their sleep. It's thought to be more likely, as I've mentioned, in children with developmental disorders, but there's not good data in Prader-Willi syndrome particularly, but these things do happen. I'm not going to talk about them in any more details, except to say that there are good treatments, and it's not necessarily something that we should accept as being part of someone having a developmental disorder. So, obstructive sleep apnea is defined as intermittent, partial or complete closure of the upper airway during sleep, and its cardinal feature is snoring, or in childhood they often make more of a obstructed breathing sound. May not be that loud vibratory snoring that shakes the walls that adults do. It can be more of a constricted, I won't try and do it because I usually choke myself if I do, but constricted sound of breathing. And this is what sort of information we get in a sleep study, where this is airflow here, and you can see this airflow as the child breathes here, and then the airflow stops. And this is the effort of breathing. There's ongoing effort against an obstructed airway, and as a consequence of these events, we get drops in oxygen level. And there are internationally recognised ways of defining whether sleep apnea is present and how severe it is, based on this sort of sleep study. Central sleep apnea, on the other hand, is an abnormality of the drive of breathing. So either from the brain or because there is insufficient respiratory, insufficient ventilation, then you get reduction in effort. There isn't any obstruction, and you can see here this effort of breathing goes down, and as a consequence you get similar drops in oxygen. And this child's carbon dioxide is sitting in the high 60s, where normal during sleep would be in the mid 40s. So there have been lots of different studies of sleep disordered breathing that's disorders of breathing during sleep in Prader-Willi syndrome. And I just want to summarise them by saying that children with Prader-Willi syndrome, and adults as well, are at risk of both central and obstructive types of sleep disordered breathing. When you look at individual studies, some say that the numbers in terms of the risk, the proportions that are affected, are very variable, and probably it depends entirely on the ages you look at, the weight profiles of the people that you're looking at, etc., etc. So, but suffice to say, either can occur. The severity is likely to be influenced by that underlying abnormality of arousal that I've mentioned, and certainly obesity contributes. It's already been mentioned this morning that right heart failure, which is cor pulmonale, used to be a frequent cause of death in Prader-Willi syndrome, and may arise in people with or without Prader-Willi syndrome as a consequence of severe sleep apnea. There's also been one small study that has suggested that sleep disordered breathing contributes to daytime behavioural disturbance. Now, this is true in typically developing children, so it makes perfect sense that it would be true in people with Prader-Willi syndrome as well. So difficulties in regulating behaviour, struggles with parents, impulsivity particularly. So it may be that if we can treat these problems, then we lead to not only improvements in well-being during the day, but also improvements in behaviour. So what treatments do we have? The main treatment for children who don't have Prader-Willi syndrome, who have obstructive sleep apnea, is removing the tonsils and the adenoids surgically. There's only one tiny study in Prader-Willi syndrome particularly, which had 5 patients with obstructive sleep apnea, and that showed a really good response to surgery. But they did have a higher rate of post-operative complications, and it's certainly known that if you've got obesity, then you're more likely to have a rocky post-operative course, so we have to bear that in mind. But there's clinical experience would suggest that the response to treatment is generally good. We sometimes use a range of other therapies, and I mention here only nasal steroids, so it's anti-inflammatory therapy that you spray up your nose, which reduces inflammation in the nasal airway. It can just give you a little bit more nasal airflow and reduce sleep apnea, particularly in mild cases. And then in more severe cases, or people whose condition is not responsive to surgical therapy, we use continuous positive airway pressure, which is CPAP, or in cases of marked hypoventilation during sleep from particular hypotonia, then we use non-invasive ventilation. And these are both delivered using a mask that sits over the nose like this, and headgear that keeps the mask on at night. There's lots of different sizes and shapes of masks, but this is generally a really well-tolerated treatment in children. including those with Prader-Willi. Now I'm just going to spend a little bit of time talking about the respiratory aspects of growth hormone therapy, and much more knowledgeable people than me have already talked about this. But I want to focus on a couple of respiratory aspects of growth hormone therapy. There's some really interesting data which shows improvements in resting ventilation and in improvements in that ventilation response to hypercapnia that I've mentioned. So not only will growth hormone potentially have positive effects on growth and muscle mass and fat deposition, it's also probably having an effect on breathing directly. Of course, there are potential risks, but as mentioned earlier, I think these are generally low and well tolerated. There was a big concern in the early days of growth hormone therapy related to sudden unexpected death of people with Prader-Willi syndrome on growth hormone therapy. And as has been mentioned, when it was looked back, there is a known risk of sudden unexpected death in people with Prader-Willi syndrome who are not on growth hormone therapy. And when you look at the causes of death in these children and older adults, sleep apnea and respiratory disorders certainly seem to be overrepresented. Now, this is not causal, but it led to a concern, I guess, about safety aspects. And then early on in the growth, as I say, in the days of growth hormone therapy, there were some cases of sudden unexpected death on growth in the early period of treatment with growth hormone, including some people who were known to have obstructive sleep apnea before they went on growth hormone. And so these findings, whilst not causal, have led us to a very cautious viewpoint about how we should manage the potential respiratory complications of growth hormone therapy. Then when you look at more robust data in terms of looking at a child's sleep and breathing before they start growth hormone and 6 weeks after, which is our typical monitoring pattern, there's a bit of variability, but there's in terms of the actual numbers that come out, and these are the 3 main studies here. But certainly there's a proportion that who do not have sleep apnea at baseline who develop it when they start growth hormone. The exact number, as I say, is not clear. Certainly it can get worse. This one actually, both children had sleep apnea at baseline, but it got much worse when they were on growth hormone. The studies that we have suggest that if you don't develop it in the first 6 weeks of treatment, probably things are going to be stable thereafter, but I'll come back to that in terms of a possible exception to that. We were interested a couple of years ago in saying, well, we're now getting referred a lot of children for baseline sleep studies before growth hormone. Can we predict who's going to have it or not? You know, these are quite complicated tests for children and parents to go through with. And it would be nice to be able to say, look, this child probably doesn't have it and doesn't need the test. But when we looked at 34 consecutive referrals for pre-growth hormone sleep studies, and the kids were aged between 3 months and 16 years, we did find 44% of them had sleep apnea at baseline. It was more likely if they were older, and I guess we're getting referred younger and younger children, as we've talked about growth hormone therapy in infancy and toddlers. And so that sleep apnea seems to be much less likely if you, at least at baseline, if you're under 2 years of age. Large tonsils are a risk factor, and it's probably the way growth hormone's mediating the development of obstructive sleep apnea, is that the tonsils and adenoids respond to that growth hormone by enlarging. BMI in this cohort was not a risk factor, but in fact most of the children were in the normal weight range. Unfortunately, symptoms weren't present in 3/4 of those with sleep apnea. So parents came to our clinic saying, my endocrinologist sent me here for a sleep study because I want to start growth hormone. We go through what that's going to involve, etc. And I asked questions about the child's sleep, and most of them didn't have any concerns whatsoever about their child's sleep. So the international recommendations now are for a baseline sleep study or polysomnography regardless of symptoms, follow-up 6 weeks after 6 weeks on treatment. We usually then would not repeat the sleep study routinely, but we certainly would want to do so if symptoms developed, and we would send a child for ENT review if they develop large tonsils or adenoids. There's this ongoing concern about respiratory infections, so a child may look completely fine when they don't have a respiratory tract infection like a head cold, but they can develop sleep apnea when they have it. But we do have unresolved questions about it. What level of post-treatment sleep disorder breathing, particularly obstruction, constitutes a risk? You know, we see children coming back with very low levels, which are statistically abnormal, but whether they constitute a higher risk of being on growth hormone at this stage, we don't know. We have seen children where the dose is increased, the dose per metre squared is increased, and having not had obstructive sleep apnea at the lower dose, they then develop it at the higher dose. So that's another time where we should be watching carefully for symptoms and repeating the sleep study if there's concern. And I want to finish just by talking about the excessive daytime sleepiness in Prader-Willi syndrome. Now this can be related to sleep disordered breathing, so if you have repetitive obstruction during sleep that wakes a child up or an adult up, they will be tired during the day, and so that's always the first thing that we cross off if we're trying to explain excessive daytime sleepiness in someone with Prader-Willi. But sleepiness can be present in and of itself, unrelated to breathing disorders. It's been found in one study to be a particular problem for caregivers if a child's very sleepy. I mean, most parents I see in my clinic, they're presenting with, not with Prader-Willi, but other children because the child has difficulty sleeping and doesn't sleep enough. But a child who sleeps excessively can also be quite difficult to manage in terms of just everyday activities. And it does seem to be related with the severity of behavioural problems. We need to remember that this sleepiness can occur despite actually increased nocturnal sleep, so it's not about not getting enough sleep, it seems to be a primary problem. Other features of narcolepsy may be present, and these are rather odd, and I always ask people, particularly parents of older children with Prader-Willi or marked daytime sleepiness about it, and they are the features where REM sleep intrudes at times where it doesn't belong. So particularly in wakefulness, you can get sudden hypotonia, so loss of muscle tone, and during wakefulness, it's usually triggered by strong emotion, which in childhood is most often laughing. So if they see a funny thing on TV or you tell them a joke, they'll have that unrestrained laughter of childhood and their legs will go wobbly and they'll fall to the ground. Much rarer features of narcolepsy are sleep-related paralysis, so people who wake up in the morning and feel awake but can't move temporarily. Again, that's the hypotonia of REM sleep intruding into wakefulness. And they can also have mainly auditory hallucinations, so just dropping off to sleep, hearing strange things, usually hearing or seeing strange things. So I ask about these odd questions in sleep clinic, but they can be clues and triggers to the presence of secondary narcolepsy. Thank you, that's all I have to say, and I'm happy to take any questions.